Hello everyone, it's me Dr. Ayaz Ahmed, working as an aesthetic dermatologist. So I was discussing about uh, regressive melanoma, malignant blue nevus, and sinonasal melanoma. So these are the actually clinical features of melanoma. So due to inflammation, uh, melanoma usually undergo regression, leading to height melanoma, which is usually visible as a irregular focus of hypopigmentation. Malignant nevus is a rapid pigmentary change in color of common nevus, while sinonasal melanoma, the presentation includes epistasis and nasal obstruction. Extension into orbit, brain, and cranial nerve leads to poor prognosis. This is a picture of regressive melanoma. Whenever there is an inflammatory change or whenever there is the inflammation, these melanoma regress in size and they are not visible clearly and seen as a mist area or mist melanoma. This is the sinonasal melanoma. You can see this area is actually malignant area or sinonasal melanoma. It leads to epistasis and nasal obstruction. Strategy for early detection. So there are some general principles which are very much important for early detection for greater improvement and prognosis. Melanoma have different biological aggressiveness leading to poor prognosis. Melanoma arise in a high risk group. Limitation of early detection and targeting right population. Aggressive tumor have low mortality. More aggressive tumor have more mortality. High risk population having light skin type and high number of the neighbors are the most susceptible individual. Breast flow thickness does not correlate with delay of diagnosis. Now, dermatological periodic monitoring, education, and self examination. Family history and great number and greatest atypical mole syndrome are noted by a dermatologist while examination. So, family history and great number of atypical mole are required for the melanoma. Education and self detection of any malignant change are effective. Screening for general populations are usually difficult. Occasionally, screening and melanoma they give public awareness. Opportunistic screening by GP doctors depend on skill. Systemic periodic screening and public health educations are needed. Investigation. Histopathology is gold standard test for diagnosis. It also gives prognostic information. Histopathological criteria of melanoma are melanocytes appear at dermal epidermal junction and at dermal dermis and form aggregates or nest-like structure. Variation in size, shape, color, and possess asymmetrical structure of navy. Another investigation is the maturation gradient, that is from epithelioid to neuroid. Fourth is the pagetoid spread. It means upward migration of atypical melanocytes. And fifth is the cytological features, which are prominent nuclei and mitotic activity, which is usually abrupt change in cell type. Main pathological pattern of melanoma diagnosis. Some melanoma develop at dermal proliferation, raising epidermis. Other tumor represents horizontal intraepidermal lentiginous pattern. Some have junctional pattern made up of nest and have pagetoid migration with dermal invasion. Melanoma with dermal proliferation. So nodular melanoma shares some characteristic feature. It arises from epidermis and move down into the dermis. The differential diagnoses are lymphoma and Merkel cell carcinoma. Extensive radiological examination is required to search for metastasis. Melanoma present with atypical lentiginous pattern. Melanocytes spread along dermal epidermal junction, appear as a crowded and follow appendicular structure, forming nest of dendritic or spindle shaped. This pattern is commonly seen in melanoma of sole and chronically sun-exposed area in elderly people. Example ALM. Melanoma present with junctional and intraepithelial pattern. It has two components, epidermal consisting of melanocytes proliferation forming nest and pagetoid spread, usually called as the in situ melanoma. Dermal component usually having epithelioid cytology with horizontal and vertical growth phase. Appearance like atypical and dysplastic nevus showing cellular atypia. Rare misleading melanoma pattern. This is of number first is the desmoplastic melanoma. Features are spindle shaped melanocytes with little or no pigmentation. Scar like fibrosis in dermis. Differential diagnoses are cutaneous sarcoma or undifferentiated squamous cell carcinoma. Staining with S100 protein usually mark spindle shaped structure. HMB45 antigen is negative. Second is the spitzoid melanoma. It's like a epithelioid or spindle shaped nevus, often a melanocytic associated with hyperplasia and mitosis. Third is the regressive melanoma. It has no longer characteristic features of melanoma, as I have already discussed, mistaken for regressive Sutan nevus or non-diagnostic. Malignant blue nevus. It's a very rare as compared to blue nevus pigmentation may obscure cytology. Animal type melanoma. It has a spindle shaped or epithelioid melanocytes that mimics melanoma of grey horse. Immunohistochemistry. This technique is applied in amelanocytic or poorly differentiated melanoma. S100 protein is expressed by 99% of all melanoma and melanocytic nevi. HMB45 is the most specific but lacks sensitivity. HMB45 is helpful in a rare S100 negative melanoma or positive non-melanocytic tumor. Marker for melanoma are Melan A, which is also called as the MART2, and MITF, more sensitive than HMB45. Novel techniques. There are two techniques which are considered to be a novel techniques. Number first is the fluorescence in situ hybridization or FISH technique. It allows direct visualization of histology of tissue targets. Second is the comparative genomic hybridization or CGH techniques. It detects gain or loss of chromosome on targets, tissue targets. FISH is better than CGH for evolution of genetic aberration in melanocytic proliferation. Prognostic marker metastasis to the skin and subcutaneous tissue it's the number one prognostic factor marker. Metastasis to lung, brain, bone, and liver. Third prognostic marker is the detection of clinically undetectable nodule or node in the first draining node. Pathological marker of primary melanoma. The pathological marker are thickness, which is usually known as the Breslow index, central node status, ulceration, mitotic rates, regression, age, sex, and location. This is a picture which is very commonly used or commonly applied for the measurement of depth of melanoma. This is known as the Breslow depth measurement. It usually take measurement from top of the skin, usually from granular layer up to the deepest part of melanoma. For example, this tumor is arising from granular part of epidermis. It's go downward, downward, downward till the depth of dermis. So we usually measure the depth from granular area up to the deepest part of tumor. Now here you can see the range of the tumor is less than 0.8. In this 0.8 range, first and second part meets, but third and fourth and fifth stage of the tumor usually go downward. So this is the bracelet thickness uh, in tumor. For example, in stage 1 tumor, the bracelet thickness is less than 1 millimeter, and in stage 2 it is 1 to 2 millimeter. In stage 3 it is 2.1 to 4 millimeter. In stage 4 it is greater than 4 millimeter. So in stage 1, whenever the bracelet thickness is less than 1 millimeter, the chance of survival is 80 to 90 percentage. In stage 2, bracelet thickness is 1 to 2 millimeter, the chance of survival is 70 to 80 percentage. In third stage, the bracelet thickness is 2.1 to 4 millimeter, the chance of survival is 60 to 70 percentage. In stage 4, the bracelet thickness is greater than 4 millimeters, so the chance of survival is greater than 50 percentage. In situ tumor, and this is actually the first stage. Before first stage, whenever new tumor appear, the chance of survival is 90 to 100 percentage. Means early detection of a tumor uh, leads to good prognosis. Management. The management of tumor is surgery. So first confirm tumor by biopsy and then go for surgery. Thank you very much. Stay connected and subscribe my YouTube channel.